All right, thank you so much. I am really excited to be here and talk to you today. Anyone who has heard me speak in the past will know that what I will say multiple times, over and over, is just because you've had cancer does not mean you can't have a good quality of life. Okay, so I'm going to do a little bit of an overview about what menopause is, why cancer treatments impact menopause, what are treatment options for people who have the most common symptoms, which are menopausal hot flashes, and what's called genitourinary syndrome of menopause, all of the vaginal dryness, sexual complaints, urinary complaints. I'm going to talk a fair amount about hormone therapy. There's a lot in the press nowadays about can you take hormone therapy if you've had breast cancer. And then I'm also going to talk about testosterone because that's also in the press a lot. So just a couple definitions. Menopause is defined as a year without a period. The average age in the United States is 51 and a half. It does not apply to people who have a progestin IUD, so something like a Mirena IUD, because that affects bleeding, so it doesn't apply to them. It also doesn't apply to cancer survivors who are on tamoxifen, because tamoxifen can affect people's menstrual cycles. Perimenopause, defined as the months or years preceding menopause, during which time people's cycles can change and they can experience all of the same symptoms that you see in menopause. But it is really a confusing time because people may still be having their period and wondering, what's wrong with me? The average length of time of the perimenopause is 4 to 6 years, but note it can go on as long as 14 years. And I tell people that let's say you're destined for an earlier menopause in your late 40s. That means you could be in your mid-30s when you are starting to experience perimenopause. And most people in their mid-30s, hormonal dysfunction is not on their radar. So this is a nice little graph because I think this gives you a sense of what's going on with hormone levels during the perimenopause. I think most people in this room probably have some memory of what puberty was like and all of the emotional ups and downs. Well, the perimenopause is just the opposite of that. So people feel very, very similar in terms of all of the emotional ups and downs. And then what I want you to see is if you look at that graph, it can start in the 30s, like I said, and people are not thinking about menopause typically when they're in their mid or sometimes even early 30s. And one of the things that I want you to realize is there are estrogen receptors all over the body, and so people can feel changes everywhere. We have estrogen receptors in the mouth, the brain, the hair, the skin, the heart, the bladder, the vagina, the vulva, joints, and bones. And estrogen withdrawal is real. I think for a long period of time, women are oftentimes told, just deal with it, you'll get through this time of life. Estrogen withdrawal is real, and there is no reason that people need to just deal with it. So this is a list of just some of the symptoms that you can see during perimenopause and menopause. I read an article that said there's 50 different symptoms that people can experience. Certainly there's the common ones. I think most people know when you go through perimenopause or menopause, you'll start feeling things like hot flashes and night sweats. With that, or even separate from that, is oftentimes some sleep difficulties. You can get fatigue. You can get brain fog because you're not sleeping well. You can get mood changes, irritability. If you are prone to something like anxiety or depression, that's a time period in life where you may get that occurring. There are estrogen receptors throughout the vagina, and people can get vaginal dryness, painful penetrative intercourse, difficulty achieving orgasm, decreased sex drive, weight gain. Estrogen affects our metabolic functioning, urinary urgency, leakage, stress incontinence, recurrent urinary tract infections, hair, skin changes, itchy skin, dry mouth, joint pain, irregular heartbeat, changes in bowel function, and many, many more. What I oftentimes tell people is, if you are at this point in life, and typically we're going to talk about how cancer impacts that, but typically for people who are in their 30s, and more often we really start seeing perimenopause for most women in their 40s, and you are not feeling yourself, at least have it cross your mind that that could be related to hormonal changes. So why do some cancer therapies bring on earlier menopause? One of the most common reasons is chemotherapy. So chemotherapy affects rapidly dividing cells, targets cancer cells, but it is not specific just to cancer cells, and it affects the follicles in the ovary. And whether someone has permanent chemotherapy-induced menopause depends on how much chemotherapy, what type of chemotherapy, and the age of the patient. So at least for breast cancer chemotherapies that are typically used, if someone's under 35 when they get chemo, they'll almost always get some return of ovarian function. If they're over 45, most times it's permanent menopause, and then over 40 it's variable. Studies say anywhere from 30 to 70% of people may have permanent menopause. And that's because they define it differently. Some people will say, well, the studies look at 1 year later, 2 years later, 4 years later. So the studies are kind of variable in how they define menopause. But the take-home point is, if you're over 40 when you get chemotherapy, there is a chance that you may have chemotherapy-induced menopause. If you get radiation to the pelvis, that's going to damage the ovaries, and that can cause menopause. Then there are some people that, as part of their cancer treatments, they will be recommended to have their ovaries out, and that will cause immediate onset of surgical menopause. We have less data with some of the newer targeted and immunotherapies as to whether they affect ovarian function. So by and large, the reasons why you see earlier in menopause in cancer survivors is from chemo, radiation, and surgery. I would also say, because of the abrupt onset of menopause in cancer survivors, oftentimes we see more severe symptoms. Doesn't mean that it lasts longer, but if someone goes from having normal ovarian function to boom, right into menopause, those symptoms are oftentimes more severe. Why do some cancer therapies also cause menopause symptoms? Well, many cancer survivors, particularly those with breast cancer with hormone-positive disease, are going to be treated with hormonal or endocrine therapies like tamoxifen or aromatase inhibitors. Tamoxifen affects menstrual cycles, and as a side effect, it can cause hot flashes and night sweats. Aromatase inhibitors, commonly used, they function as a cancer drug to shut down all estrogen production in the body. Because the vagina, vulva, bladder are very rich in estrogen receptors, people on aromatase inhibitors can get horrific side effects. I'm going to talk a little bit more about it afterwards, but they can get really, really severe vaginal symptoms, symptoms of what we call genitourinary syndrome of menopause. So how do we manage all of the common symptoms like the hot flashes and night sweats? One thing is, I think sometimes people don't think about lifestyle options. Dressing in layers, making sure you can do things like sleep with a fan, open window, looking for your triggers. For a lot of people, certain foods will trigger hot flashes. Caffeine, chocolate, alcohol, spicy foods. Understand what your triggers are, and then you can avoid them. Some people who eat too close to bedtime, as their body is metabolizing that food, it will give off heat, and it will worsen nighttime hot flashes. So we tell people don't eat for at least 3 hours before going to bed. So lots of lifestyle things that can help out for mild symptoms. Then there are a whole host of prescription meds. I think a lot of people get told, well, no, you shouldn't use hormones, so just deal with the side effects. Whole host of prescription meds. All of these low-dose antidepressants listed, there have been studies that have looked at all of them as an alternative to hormones for managing hot flashes. These anticonvulsants and neuropathic pain relievers like gabapentin and pregabalin. There's an overactive bladder medicine called oxybutynin. Now, those are all really diverse drugs, and the only thing that those drugs have in common is they cross the blood-brain barrier. And we used to say we're not really sure why they impact hot flashes, but anything that crosses over into the brain can affect the temperature regulation zone in the brain. I'm going to talk in a moment about two of the newer FDA-approved drugs that we actually understand how they work in the brain to decrease hot flashes. But many people don't realize that we have FDA-approved options for treating hot flashes in cancer survivors. We have one is a brilliant marketing ploy. How many people have heard of the antidepressant Paxil, right? Most people know what Paxil is. The lowest dose that exists for Paxil when used for depression is 10 milligrams. They studied a lower dose for hot flashes, 7.5 milligrams, found it effective, got it through the FDA, and changed the name to Brisdil so women don't have to think they're on an antidepressant. But that is low-dose Paxil. It's FDA approved. On the next slide, I'm going to talk a little bit about these new drugs, Veozah and Linquit. There are also integrative options. We have good data for things like cognitive behavioral therapy, mindfulness, mixed data on acupuncture, but it can help out with many things. Pain, there's some evidence for sleep, relaxation therapies, and then there are herbs and botanicals. We have a little less data with that because those are classified as foods and not drugs, so you oftentimes don't have the big pharma supporting big clinical trials, so we have less studies on those. What I tell my cancer survivors who are interested in knowing, can I use this specific herb or supplement? There are trackers that you can look at to say, I'm on this drug, does it interact with this herb? Many times the oncologist will say, I'm not sure, I don't know anything about black cohosh or things like that. So oftentimes I'll tell people, make sure you're seeing someone who does know about these supplements, but you yourself can also look because there are free trackers that exist. So a little bit of a deeper dive on some of these prescription alternatives. One of the things that's really interested in is if you look at some of the drugs like the antidepressants, the doses that are used for treating hot flashes are much lower than the doses used for depression. It's not going to be an effective mood stabilizer. For example, one of the most common ones, a drug called Effexor. When they use it for depression, the doses go up as high as 375 milligrams a day. Most effective dose for hot flashes is 75 milligrams, and you will not get much of a benefit for hot flashes if you go above that. Oftentimes, also, when you're using these drugs for depression, it will take weeks to have an effect versus days when you're talking about hot flashes. We oftentimes take advantage of the side effects of the drugs when we're deciding which ones to use. So gabapentin, often used after cancer surgeries for neuropathic pain, like after mastectomies on the chest wall, well, that can cause some sedation. So if we have some people having their hot flashes at night, sometimes we'll give them a very little low dose of gabapentin before bed. Oxybutynin, that's an overactive bladder medicine, so people who have urgency and frequency. So if I have someone who's waking up in the middle of the night because their bladder wakes them up to pee and they're having hot flashes, that's going to be a drug we may try. Generally, we don't mix and match. We try one thing at a time. When I mentioned low-dose Paxil, whether you're talking of regular dose Paxil or Paxil, there's some concern for breast cancer survivors on tamoxifen that it is a very potent inhibitor of the part of the liver detoxification pathway that also metabolizes tamoxifen to its active metabolite. So some oncologists will want people who are on tamoxifen to specifically avoid the drug Paxil. Now, these newer drugs, one is called fezolinetant Veozah, the other is called elinzatent or Linquit. Veozah, the first time I heard about it, it was advertised at the Super Bowl in 2023. Like, how is that to get a hot flash drug advertised at the Super Bowl, right? So these drugs are really interesting drugs because it turns out that hot flashes occur based on a very specific area within the hypothalamus of the brain where what are called the KNDy neurons are located. And there is this KNDy neuron signaling, and these drugs target what's called the neurokinin 1 and 3 receptors. And it affects these KNDy neurons, and it can tamper down the effects of dropping estrogen. So it's the first drugs in the pipeline that we understand exactly how they work. Veozah hit the market in 2023. When they did the trials that led to its FDA approval, they excluded cancer survivors, but there's nothing about the mechanism of action that a cancer survivor can take it, and we are using it most often in cancer survivors. That one is FDA approved for hot flashes. When the drug came to market, they saw very few cases of liver toxicity. And this past year, the FDA slapped a black box warning on it that says, you got to check liver functions baseline months 1, 2, 3, 6, and 9. So it's a little bit of a hassle to use that drug, but it is very effective for hot flashes, and one of the first drugs it was the first drug we had in the pipeline that we know exactly how it works. 2 weeks ago, the other one just got FDA approval, this Linquit. What's interesting about this drug is Linquit targets what's called both the NK1 and the NK3 receptors, and targeting both those receptors, it's thought to help not just with hot flashes, but with sleep. So a lot of people have sleep dysfunction. I think that's going to be a really interesting drug. Right now, it's hard to even get it yet. It just got FDA approval at the end of October. I've heard it's got a really high price point, like $850. Hopefully insurers will start covering it. The problem with these drugs, once they first come out, it takes a little bit for them to get onto insurance plans. But I'm really excited because this is just more tools in the toolbox saying no one needs to suffer. And generally, when we stop these drugs, we wean slowly to minimize any side effects from abruptly stopping. Main point, again, I will keep saying it over and over, plenty of options, no one needs to suffer. I want to switch to genitourinary syndrome of menopause. So this is a collection of signs and symptoms that are caused by lowering estrogen levels, and it affects specifically the vagina, the vulva, and lower urinary tract. GSM causes vaginal dryness, burning, painful sex, urinary urgency, burning, and frequent infections. It is progressive, and it can impact not just someone's physical, but emotional and sexual health. Why do cancer survivors experience so much genitourinary syndrome of menopause symptoms? Well, one is because that immediate onset of treatment-induced menopause. Also, for cancer patients who get radiation effects on the vaginal tissue can exacerbate GSM symptoms. And then the people that I see in my practice, I see it most often for women on aromatase inhibitors. So most estrogen in women's bodies comes from the ovaries. If we send someone to the lab to measure their hormone levels, we're measuring ovarian production of estradiol. But we all make weak forms of estrogen in other cells in our body. And aromatase inhibitors work by shutting down all that peripheral estrogen, so someone is more shut down than menopause. These symptoms can be so severe that people sit and the vagina feels like sandpaper. They pee and they wipe themselves and the tissue can tear. I will tell people, no one normally thinks about your vagina, right? You want to use it, you tend to use it and not think about it. If you're on an aromatase inhibitor, you want to have sex. Unfortunately, you need to think about the vagina and you need to work on the tissue regularly. So what are ways that people can work on the tissue? First, there's a bunch of over-the-counter things. They don't change the tissue, but if they're used frequent enough, they'll make the tissue feel better. And there's many, many different things. If you do a search, you will find 50 or more things that come up. So there's moisturizers. Moisturizers are different than a lube. A lube is something that is used prior to sex to decrease pain associated with friction. A moisturizer retains water and is recommended to be used on a regular basis multiple times a week, and it provides longer-term relief. There's oils. Oils penetrate thin tissue and makes it feel really good. You can use them on the inside, on the outside. The vagina is not a sterile area. There's pH-balanced products. So sometimes the normal pH of the vagina is very acidic, and that keeps people from having infections. When that pH changes and it becomes more basic, people can be prone to getting things like yeast or bacterial infections that can cause a discharge, itching, smelly discharge. There's pH-balanced moisturizers that can restore the normal environment of the vagina and decrease the likelihood of those infections. There's soothing agents for vaginal or vulvar pain. There's moisturizers with CBD. They're putting CBD in everything nowadays, right? Topical anesthetics for the opening. I will tell people, you can use lidocaine as over-the-counter. You can rub a little local lidocaine along the vaginal opening 10 to 15 minutes prior to any penetrative sex. Doesn't affect deep sensation, but it will help out with entry pain. And then there's many different lubes for sexual activity. So lots of over-the-counter things that I think are important for people to know about and use. What about vaginal estrogen? Well, the benefit of vaginal estrogen is you are targeting the tissue of concern. You get almost none, if any, absorption into the bloodstream. So that means fewer side effects. It comes in many different ways: creams, rings, and suppositories. In general, for women who are on aromatase inhibitors, we have said to use the ring or the suppository forms because they have been studied in breast patients. We at UCSF did the largest study to date looking at this vaginal yeast ring for women on aromatase inhibitors, and we've shown that the dose of hormones stay locally in the vagina without absorption in the bloodstream. People, with the creams, when you put a bunch of cream in the vagina, the surface area is greater, and there's some theoretical concerns that it could lead to absorption in the bloodstream. Despite that, I show you this article on the right-hand side. This came out a year ago, and it was this big meta-analysis that basically showed there are absolutely no studies that show the use of vaginal estrogen impacts survival from breast cancer. Breast cancer patients can use vaginal estrogen, as can GYN cancers. Any cancer patient can use vaginal estrogen. Even for women on aromatase inhibitors, if we're going to recommend cream, a suppository or a ring, people can rub a cream into the opening or on the outside. That's not going to cause any absorption into the bloodstream. But vaginal estrogen is safe. The mechanism is thought to be that estrogen improves blood supply, which improves tone, makes the tissue better lubricated, less uncomfortable. A lot of people will come in and ask, well, what about lasers? Who's heard of Mona Lisa? Anybody? So the Mona Lisa is the most common one that I think people have heard of. There's others called the YAG, and then there's all these energy devices, FemLift, FemTouch, all of these different ones listed. They each work a little bit differently, but essentially what they do is they cause micro trauma to the tissue, and then you get new blood supply and new connective tissue coming in to cause healing. None of these are FDA approved for that indication, which means they're out of pocket. And they're pretty expensive, usually $3,000, $3,000 to $4,000 for 3 or 4 treatments over the course of a year. They say that women on aromatase inhibitors where the tissue's really, really dry may need even more treatments. It's done by some gynecologists, plastic surgeons, dermatologists. The FDA a few years ago put out a warning statement saying, look, these aren't FDA approved, they may cause burns. In the trials, we have not seen burns. The problems when you start looking at the studies that have been done is they all have different endpoints. Some are for dryness, some have for vaginal rejuvenation, which as a gynecologist, I don't know what that means, but all different endpoints, incontinence, pain. And they also use different settings. And so it's hard to compare different trials when they're using different settings. But overall, the trials have shown some success. And I'll tell people, look, if money isn't an issue for you, you are open to doing something that you're going to have to pay out of pocket, and we have limited data, but the data we have says maybe it will be helpful, I can refer to people who will do that. Okay, I want to focus a little bit on hormone therapy because that's getting a lot of press these days. So, what is systemic hormone therapy? Systemic hormone therapy means hormones that get into the bloodstream. And it includes either estrogen alone or estrogen with some form of a progesterone. In general, estrogen is the component of hormones that makes people feel good, but if you have a uterus, you got to use some form of a progesterone because estrogen can thicken and build up the lining of the uterus, and if used alone, it can increase the risk of uterine or endometrial cancer. So if you have a uterus, you counterbalance the estrogen with some form of progesterone. Hormones come in many different ways. It comes in oral forms, it comes in patches, sprays, gels, vaginal rings. It is the most effective treatment for managing all of the perimenopause and menopausal symptoms that we talked about. No one will ever argue about that. And unless someone has other health reasons that they shouldn't be using hormones, for a cancer survivor that has had treatment-induced menopause, if it is not a hormone-sensitive breast cancer or certain advanced stage GYN cancers or certain ovarian cancers, other survivors can use hormones. So unless they have another reason, this is the most effective treatment. And really the main controversies that if you pick up and read anything these days, the main controversies have been in breast cancer. So, just some general information about hormones. We now know there is something called the timing hypothesis. And the timing hypothesis says that the risks and benefits of hormones differ depending on the age of the patient and years since menopause. And if you start hormones soon after menopause, within 10 years of menopause, not only does it treat all of these symptoms, and like I said, the most effective treatment, but it also is protective for heart disease. And heart disease is the #1 cause of death in the general population. It's protective for heart disease. We know that estrogen also protects against bone loss or osteoporosis. There's increasing data that suggests there's a window of opportunity for starting it where it may be protective for cognitive loss. And there are studies that say if hormones are started in that appropriate time period, that it's associated with lower all-cause mortality, lower likelihood of dying from anything. Get a lot of questions about, can you use hormones in the perimenopause? And the answer is yes. If we have someone who's still having periods, but they're having all these symptoms, we can use hormones. One of the things to realize is the dose of hormones that are in hormone therapy is about 1/3 to 1/5 of what's in a birth control pill. So it doesn't provide contraception. And it also means sometimes when people have their perimenopause symptoms, they oftentimes have irregular or heavy bleeding. Hormone therapy is not going to fix that. So if someone's having irregular or heavy bleeding, they would do better with something like an IUD, which tends to control that heavy bleeding. But if someone just needs control of some of their symptoms, they don't need contraception, they're not having abnormal bleeding, it can be used. Now, this I know is a busy slide, but I'm going to spend some time talking about hormone therapy and breast cancer and what do we know. So, if you go back, estrogen hit the market in the 1950s, I believe, and by 1960s, it was one of the most commonly prescribed drugs. And by the 1970s, they started realizing, wait a sec, if women take estrogen alone, that increases the risk of uterine cancer. So by the 1970s, they started adding progesterone to combinations. And they started noticing that women who were taking hormones seemed to be healthier and have lower risk of heart disease. So people said, Maybe we should be giving it to people who are really risk for heart disease. They're obese, they're smokers, they have hypertension and high lipids. Then in the 1990s, there was the first well-designed trial that said, well, let's look at women with heart disease who've already had a heart attack and see if you give them hormones and see, does it protect against a secondary heart attack? And lo and behold, it did not. And people said, well, that's sort of interesting, but what you want to do is look at healthy women who don't have heart disease and see if you give them hormones, does it protect against heart disease? And that was the design of this very large trial called the Women's Health Initiative. And the results from that trial have affected how everyone thinks about hormones to this current day. And it has also, I would say, affected why anyone who's trained in medicine in the past 25 years has not gotten adequate training in menopause. So in the WHI, they were interested in looking at heart disease. So they looked at an older age population. We already said the average age of menopause is 51. They looked at an average 63-year-old. And they were given a very specific type of hormones. It was called, the estrogen was a drug called Premarin, and the estrogen and progesterone was a drug called Prempro. Those were the most commonly prescribed drugs in those days. In the 1990s, there were 27% of all menopausal women were using that. Just to compare, in 2020, the use of hormones across this country is 5%. So that's what's happened since this WHI. In the WHI, looking at this specific type of hormones, there was a lot of bad press in 2002 when the Prempro arm of the study was stopped short when it showed it didn't protect against heart disease and it surpassed the threshold for breast cancer. That's when every woman started calling their doctor saying, hormones must cause breast cancer. Press totally takes off of that, and that has influenced how we think about hormones to this day. Now, when the WHI came out, the estrogen-only arm did not find that. It continued, and it stopped 1 year earlier, not because of breast cancer. It stopped because it didn't protect against heart disease, and there was a higher risk of blood clots and strokes. But at that time, they saw a lower risk of breast cancer. Now, these women have been followed out to current day. And we know that we've looked at breast outcomes, cardiac outcomes. Turns out when they looked at women in that study who were within 10 years of menopause, hormones actually did protect against heart disease. And that's what led to that timing hypothesis that said, look, if you start people early, you do get cardiac protection. But if you start them late, they probably already have plaques in their vessels, and you can give them hormones which are thought to like modify the coronary vessels, and it's not going to influence the risk of heart disease. So that's one thing we've learned since then. They also followed women out to current day looking at breast cancer outcomes. And this was published 5 years ago in JAMA, one of the most premier medical journals, and they showed the group that got Prempro, estrogen with the synthetic progestin, versus placebo still had a higher risk of breast cancer, no difference in dying of breast cancer. The interesting thing is the group that got estrogen alone, statistically lower risk of getting or dying of breast cancer. So that showed us if there's a component of hormones that impacts breast cancer, it's the progestin and not the estrogen. And nowadays, when we use hormones, we don't use those synthetic forms. We use what's called bioidentical. Bioidentical hormones are similar to what your body produces, and there is increasing data that suggests bioidentical hormones are more breast neutral. So by and large, the studies that have shown a higher risk of breast cancer are confined to studies that use synthetic progestins. We also use formulations of hormones that are safer from a blood clotting perspective. Oral estrogen can increase the risk of blood clots, which means strokes. Turns out if you use estrogen in a patch and you bypass first-pass metabolism through the liver, it affects clotting profiles differently, and it doesn't increase blood clot and stroke risk. So we use much, much safer forms of hormones these days. Now, there have been studies that have looked at the use of hormones after hormone-positive breast cancer. And the problems are the two big, large studies showed mixed results. One showed a higher risk of recurrence, one did not. The problem with those studies is older formulations. The gap in the literature is us having enough or any real good quality studies looking at current formulations of hormones in women with hormone-positive breast cancer. That is a gap in the literature. The other thing I tell people is not all hormones are the same. I don't know if anybody has heard of this drug called Duovy. That's been FDA approved as a type of hormone since 2012. And it is an estrogen, and instead of combining it with a progestogen to protect the uterus from uterine cancer, it combines it with the cousin drug of the breast cancer drug, tamoxifen. Now, tamoxifen can actually increase uterine cancer risk, but these drugs that are called SERMs, which is what tamoxifen is, they all act differently in different tissue, and the one in this Duovy happens to protect against uterine cancer. So it protects against uterine cancer, and there's some preliminary trials saying it may be preventative for breast cancer. So a study that was done at ASCO this past June looked at women with DCIS who were randomized either to Duovy or placebo before their surgery, and they found at the time of surgery, the ones that got Duovy had fewer proliferative effects on the breast. So this is a really interesting type of hormones that may be preventative for breast cancer. So with all of that in mind, how do we counsel people? First, I just want to talk about breast atypia and DCIS. Atypia, atypical ductal hyperplasia, lobular hyperplasia, DCIS. DCIS, the reason why I put it into this group is you can never die of DCIS. You can die of invasive cancer. The problem with DCIS is it can come back, and we have not done a good job of predicting who's going to get invasive cancer after DCIS. First line recommendations is always going to be to use non-hormonal options, and like I said, we got lots of them. Off-label Duovy if someone's menopausal. That drug is a menopausal hormone therapy, and we at Mindy, we will offer it off-label. At UCSF, they're doing a study for women with DCIS and breast atypia and Duovy. Standard menopausal hormone therapy is okay if someone had DCIS and they chose bilateral mastectomies. So you certainly do not need to do a mastectomy. There's no difference in outcomes with mastectomies, lumpectomy in the setting of invasive cancer. When someone has DCIS and they remove both breasts, the likelihood of getting invasive cancer after that is 1% to 2% over their lifetime. So we will standardly give those patients hormone therapy if they want. If people have breast tissue remaining, they had a lumpectomy or unilateral mastectomy, it's shared decision making. Talk about what we know about hormones, what we don't know, the gaps in the literature, looking at current formulations of hormones in people who are high risk. But if people understand that, we are willing to offer them hormone therapy. We work with someone's breast team to make sure that we're all on the same page when we do that. Hormone-negative breast cancer. We have no data that the use of hormone therapy in the setting of hormone-negative breast cancer increases risk of recurrence. There are some oncologists that will say, ooh, but I'm afraid that hormones could activate some other non-hormonal pathways, and once you've had cancer, you're at risk for another cancer. But there is no data that says it impacts survival from hormone-negative cancer. Usually we wait till people are free of disease for a period of time. Once someone's hit 5 years, in this setting, they're considered cured of that cancer. We will offer hormone therapy. Less than 2, there's a high risk of recurrence in that first couple years. We tend not to. And between 3 and 5, we're going to work with someone's oncologist to say, do you feel comfortable if we started hormone therapy? Again, we should all be working together as a team. Hormone-positive breast cancer. Non-hormonal therapies should always be first line. Again, we have lots of them. I will tell people the data looking at the use of hormones after hormone-positive breast cancer has been mixed, but that data looked at older formulations of hormones. There are gaps in the literature. We do not have studies looking at current forms of bioidentical hormones in people with hormone-positive breast cancer. If someone is on tamoxifen or an aromatase inhibitor, that's not when we would offer hormone therapy. If someone is post 5 years treatment, and at Mindy we chose 5 years because we know the shortest period of time that an oncologist is going to recommend tamoxifen is going to be for 5 years. After that 5 years, we know there are reports with early stage breast cancer that you can see late recurrences, but we will do shared decision-making with patients after that time period. Now, the big thing that I want you to get is that breast cancer is not breast cancer is not breast cancer. They are all, it's a compilation of a number of different diseases, and you need to individualize when you're talking about controversial areas like the use of hormones. We are hoping at Mindy that we're going to be able to get this data. We see 20,000 patients a week, not all cancer survivors, but we're starting to collect information, and I am hoping that we're going to be able to do studies so that we can help determine, is it safe for us to be giving hormone therapy after hormone-positive breast cancer? The last area I just want to mention is testosterone. Lots and lots of interest in this. So it's important to know that the vagina and the outside vulva and urinary tract are rich not just with estrogen receptors, but also male hormone androgen receptors. The best evidence for using testosterone in women is for improving low libido, low sex drive in postmenopausal women. There was actually a patch that was made for women, a testosterone patch that showed benefits for improving sexual functioning in postmenopausal women who are on hormone therapy. They went before the FDA in the early 2000s. The WHI had just come out, and the FDA said, we're not approving this until you show us long-term safety data with regards to the breast. To this day, it's not been FDA approved for women. That's one thing. The other thing is, because of all the doping scandals with people using steroids, testosterone ended up getting put on a DEA list. So it is a controlled substance. So it is a hassle for women to use, because either you can use 1/10 of a male hormone dosing, but with controlled substances, you're only allowed to get a 3-month supply legally, and to get 1/10 of a male hormone dosing, it often means the pharmacist's got to break open a box and say, only use this amount, and they may not do that. So that means you need to get, oftentimes compounding is another formulation, and when you're using compounded formulations, you need to make sure that the compounding pharmacy does what's called third-party testing, so you can be sure that whatever drug they say is in it is really in it. Because there's definitely some snake oil salespeople out there that are selling compounded formulations of all sorts of things. So there's an issue around getting compounded formulations. But definitely good data about using testosterone in postmenopausal women for improving sexual functioning. Premenopausal women, there actually isn't data, but I would tell you we have a couple FDA-approved drugs in premenopausal women so that they have other options for improving libido. A lot of women coming in asking us, well, should I be on it for hormones in general? What about my bones, my muscles, my brain, fatigue? We have much better evidence in men than women for muscle mass and bone health, and you have to extrapolate data from men to women. We don't have enough evidence. It's evolving. There are studies going on. We will tell people, look, if you understand we do not yet have good evidence for any of these other areas, but you want to try it, we will be willing to offer it. What about in cancer? Well, not really much data out there in cancer survivors. I think it's most concerning about safety in people on aromatase inhibitors, because aromatase inhibitors work by taking male hormones that women have floating around in the bloodstream and converting them to weak estrogens. So if you give someone a whole bunch of male hormones, could you overwhelm that reaction? It's very complicated because there's some studies actually saying that testosterone and aromatase inhibitors may prevent breast cancer in healthy women. So it's a complex area. I will say to people, look, we don't have a lot of data in cancer survivors, so you should probably use it cautiously. But when we give women testosterone, we run their testosterone levels in values that are the same as a normal premenopausal woman. So is that dangerous? Probably not, but there isn't a lot of data. I just want to mention these 2 other drugs for improving sex drive in survivors. People may not realize there are FDA-approved drugs for low libido in premenopausal women. One is called flibanserin. It's an ADDI. None of these are hormonal, so there's nothing about them that mean they can't be used in someone with hormone-positive disease. This one was FDA approved back in 2015 and affects the neurotransmitters that are involved in sexual excitement and sexual satisfaction. It is only FDA approved in premenopausal women, which most people think like, how come you chose to study that? Usually it's postmenopausal women coming in saying my libido's off. But that's what they did. If you're going to use it in a postmenopausal woman, it has to be used off-label, not covered by insurance. One trial I've seen in cancer survivors, it's in breast patients who are on tamoxifen, who were given flibanserin versus placebo, and they found multiple improvements in sexual domains. So may be beneficial for cancer survivors, not much study at all. Again, is not contraindicated. There's nothing about the way the drug works. The other one is a drug called, the other thing about flibanserin, it's an oral pill that you have to take every day. Some people don't want to take something every day for something they may not do every day, right? Bremelanotide Vyleesi, it's a subcutaneous shot that you give yourself 45 minutes prior to anticipated sexual activity. It was FDA approved back in 2019. Again, off-label use in postmenopausal women. It is only FDA approved in premenopausal women. So for any of these off-label use, you actually got to get them in these specialized pharmacies. There is no published data in any cancer survivors about bremelanotide. But again, the mechanism of action, it's not hormonal. There's nothing about it that says it couldn't be used in people who are on drugs like tamoxifen or aromatase inhibitors. Also tell people, remember about supportive services that can help manage genitourinary syndrome of menopause and sexual dysfunction. Pelvic floor PT, vaginal dilators, devices like an O-nut ring. It goes on the base of the penis and it limits depth of penetration. So someone who's had hysterectomy or radiation and they have scarring along the upper vault, O-nut ring can limit the depth of penetration. Sex therapists. There's this AASECT, which is the American Association of Sexuality Educators, Counselors, and Therapists, and vibrators for pleasure. So lots of things that people can and should be thinking about in addition to any of these medical things. So I'll end with common questions. If we've got someone on hormones, do you have to stop at a specific age? People used to say 60. Nope. No specific age. All of the large guiding organizations now say address someone's history and make sure they haven't developed health reasons that you would stop hormones, but no reason to stop based on age alone. Can you use hormone therapy if you have a family history of breast cancer? Yes. A lot of people are told no. Doesn't mean you don't need close follow-up with imaging, exams, but you can use hormone therapy. We do not have evidence that hormone therapy further increases the risk and people are at higher risk, and the same goes for a genetic mutation. NCCN says with genetic mutations like BRCA, you make someone surgically menopausal, put them on hormones at least till the natural age of menopause. I would say we don't have data to say why are you stopping at the natural age of menopause. We don't have any data that's, I'm not sure that current formulations of hormones even increase breast risk. But we don't have data to say those people really need to stop. So need high-risk breast follow-up if you have a genetic mutation that increases your risk of breast cancer, but you can still use hormones. Can supplements, herbs, botanicals be used with cancer therapies? And I say maybe. Again, there's a lot of those that we may know less data with. I tell people to look at trackers or speak to someone who knows literature in this area. And with that, thank you, and I am happy to take questions.
Hi, Dr. Goldman. Thank
Yep.
you for the great talk. Thank you for sharing your knowledge. Quick question, what are your thoughts and perspective of using medication such as growth hormone to protect the ovaries during chemo?
So the question was, what about using medications to protect the ovaries during chemotherapy? So The best way to preserve fertility is before someone gets chemotherapy to do assisted reproductive technologies like IVF and freeze eggs or embryos if someone has a male partner. However, there have been studies that have looked at giving drugs to put the ovaries in a resting state. The drugs are called Lupron or Zoladex, and they are these GnRH analogs, and they put the ovaries in a resting state, so those follicles in a resting state before chemo, and people have then looked at outcomes. They've looked at, do people get their periods back sooner? Does it improve fertility? And does it impact cancer outcomes? It's looked at primarily with breasts. So the data that we have so far shows it seems to allow people to get their periods back sooner, and there is a suggestion of likely improved fertility and no impact on overall survival from cancer. So most times nowadays, particularly if someone can't do something like IVF, not appropriate based on their stage of disease, financial resources someone doesn't have, insurance doesn't cover it, we will definitely give them drugs like Lupron to shut the ovaries down prior to chemo.
Thank you, Dr. Goldman. My name is Joanne as well. Thank you, Joanne. I am living with metastatic breast cancer. Diagnosed before 40. Initial diagnosis was 2B, and then now, 15 years later, with MBC. I have a young daughter. Would you recommend a baseline for her, given I've had 2 recurrences?
Yep. So what we recommend for family members, certainly if someone is diagnosed young, people should get genetic testing to make sure that there isn't a gene mutation, because that is one of the times where if someone does have a genetic mutation, of which we now know of many that can increase the risk of breast cancer, if someone has a genetic mutation, it's a time where we can say, this is what caused you to get cancer. Most times we can't say this caused you to get breast cancer. Radiation to the chest wall at a young age when breast tissue is developing, or genetic mutations are times that we can tell people this caused you to get breast cancer. For many people, there's no gene mutation and we don't know why they got cancer. And so we will typically say that 10 years before the onset of the disease in the youngest family member, that the next generation needs close follow-up. So what does close follow-up mean? It means getting a breast exam, usually annually. The data on breast exam shows if it's done in the hands of someone who knows what they're doing, that clinical breast exams are useful. It means getting imaging. So imaging, if someone's under 30, we don't do mammograms because mammograms are a lousy test under 30. We do MRIs. But once someone's over 30, we would recommend imaging with mammogram. Depending on how dense the breast tissue is, we may recommend, in addition to a mammogram, an MRI. Lots of new research going on of evolving technologies, AI-assisted reads, CT-enhanced mammography, 3D ultrasounds. So things are going to be changing in the next few years, but right now it would mean mammo plus or minus MRI. On top of that, I talk to people about lifestyle. What can you do from a lifestyle standpoint? Regular exercise, specific amounts, 150 minutes a week, divided times, interval cardio has been shown to decrease risk of breast cancer, colon cancer, liver cancer, esophageal. It is the one thing people have control over. Minimizing alcohol. Breast cancer, 2/3 of breast cancers are hormone positive. Doesn't mean hormones cause someone to get cancer, but it means hormonal therapies will be used as part of the treatment. Alcohol is particularly a risk factor for hormone-positive breast cancer. So I talk to people about lifestyle things if you have a family history. Minimizing alcohol, making sure getting weight-bearing, regular interval cardio exercise, and 10 years before the onset of your first diagnosis, starting to get close follow-up. If you had a gene mutation, she needs to be checked for the gene mutation you had. For anyone who had genetic testing before 2014, we recommend going in for repeat testing because we've had these more expanded panel testings that came available around 2014. So sometimes it means getting repeat testing because it may be that we know of a gene now that we didn't know of when you were first diagnosed. Yep.
My son is, I'm still waiting for results. But I was wondering, the generation after that, it doesn't mean that they won't have like certain.
Yeah, so with genetic mutations, those mutations are passed down in a dominant fashion, which means 50% of offspring can get those. Most times when people get testing, it's usually negative for genetic mutations, and we'll say, we don't know why you got cancer. But if you have a gene mutation, we can say, this is why you got cancer. If your child did not inherit that, their risk of getting cancer is thought to be more similar to the general population, and they don't need all of that extensive follow-up. The generation beyond that, it doesn't skip a generation. So, yeah, because they're passed down 50% of the time. So it's got to go, it could get to the next generation if your son has it and has a child, or your daughter has it and has a child. But it doesn't go from you to a grandchild. Yeah, it's a great question. So the symptoms may be more severe when you have surgical menopause because of the abrupt onset, but we don't have any data that says that they last longer. Now, what I will tell people is if you had surgical menopause at a young age, you have more years to live where you can get health issues related to being menopausal. So after menopause, our risk of diabetes goes up. Our risk of bone loss, women reach peak bone density at 30 to 35. Everyone has a loss after that, but the major rate of loss is in the immediate years after menopause, where you see 2 to 3% per year. So if you were made menopausal 10, 15 years earlier than the natural age, you need to get earlier bone densities because you could develop health issues like osteoporosis or potentially cardiovascular disease. So I will tell someone, there's risk factors that you can modify. Make sure lipids are okay. Make sure you don't develop diabetes or treat that if you do. Make sure blood pressure is controlled and that you don't smoke. Those are all modifiable risk factors for heart disease. So the symptoms don't necessarily last longer, but there are health issues related to go into menopause early. So one more question I can take.
I am a 9-year survivor. Over 9 years. I'm 67. I just want to say that thank you very much for your presentation, Dr. Goldman. For me, acupuncture was very good. Very good. I did for a year, twice a week, acupuncture to take care of neuropathy and other symptoms. Secondly, I would like to say that my cancer was 80% estrogenic. So I wouldn't take estrogen therapeutic or not for anything else in the world because we have receptors for estrogen, and then those cancer cells multiply based on feeding them estrogen. This is just to inform everybody and then to inform you about my thinking.
Yeah, no, it's a good, I have many of my patients who feel exactly the same. I will tell you, there's a lot of confusing things. I showed you data that if you don't have cancer and you take estrogen alone, hormone therapy, that prevents you from getting or dying of breast cancer. But then all of a sudden you get hormone-positive breast cancer and we treat you with aromatase inhibitors that shut down all of your estrogen. So how does that make sense? And I'm not convinced we actually know whether it's effects directly on the estrogen receptors or whether it's downstream effects on potentially progesterone receptors. What I wanted you to hear is It is a confusing area, and the types of hormones we use are much safer. We do not have any evidence that vaginal estrogen impacts survival from breast cancer, and at least conversations are happening about systemic. I don't know if people saw, but the black box warning was removed off of hormones this week, and that black box warning means that black box warning was on there based on data from the WHI. We have much safer formulations. We are learning more. Doesn't mean that there are no risks, but it means those risk-benefit discussions belong with you and your clinician and not scaring people by having it on a big black box.
I want to ask a question.
Yes?
I've been standing here. Anyway. I went in May and had a mammogram. I had a pimple, and my husband told me he wasn't going to bust it. So he told me, no, go to see your doctor. I'm telling him, no, I'm not going, because all they're going to do is Lancet. I get there in August to see my doctor with a pimple, and I got breast cancer. And another thing is that I don't trust mammograms no more. That's it for me. But where I live at, in Bayview Hunters Point, where the toxins and pollution and all this stuff is at, my mom's had breast cancer. Pancreas took her home. I want to ask you about the mammograms. How positive is that? Because after that happened to me, if I didn't go, it could have went north, not listening to people that I don't. I'm a stubborn person.
Yep.
But I want to ask you, how much percentage of it is the mammogram? And then I want to ask you about, I live in Bayview Hunters Point. There's
Yep.
sewage plant over here, and there all the stuff from the
Yep.
down in the days.
Yep.
So what part of that
Yep.
is playing in my
Well, let's
stomach?
talk first. So mammograms, first of all, about 15 to 20% of the time, they may miss cancers. They are definitely not a perfect test. They don't cause someone to get cancer. People have views that does it compress the tissue and spread cancers. We don't have evidence for that. There is a heck of a lot of research going on looking at other modalities because mammograms aren't perfect. They also overdiagnose cancers that may not do anything in someone's lifetime that will impact their overall survival. So there's a lot of issues around mammogram. It is the one test that's been shown to save lives in multiple studies, but by no means is it perfect. Your question is great about environmental exposures. I think there's a lot of research trying to understand it. If you look at colon cancer is on the rise in young people, particularly people under the age of 50, and people do not know why. And there is a lot of interest of whether that particularly could be related to some sort of environmental exposures. And people have wondered also, we see higher risks of breast cancer in young women. It's not going up in women over 50, younger women it is. So could that be due to some form of hormones that are in cosmetics or things like that? Lots of interest in that. I would say we don't have definitive data. The other big area is stress. Like, we all live in stressful times. There's increasing data that says stress causes local cellular inflammation, and inflammation is involved in metabolic disease, it may be involved in cognitive loss, and it may be involved in cancer development. That's an area we are just starting to get a handle on. So I can't tell you for sure, but certainly there could be things that impacted it. I think, am I allowed to take more questions, or should I be stepping off? Step off? Okay. Thank you all very much.